Assalamu alaikum wa rahmatullahi wa barakatuh. Our lecture today is about diabetes mellitus in pregnancy by Dr. Udail Husseini, board certified doctor in internal medicine, Somar College of Medicine. Pregnancy makes glycemic control more difficult in pre-existing type 1, which is insulin dependent diabetes mellitus, and type 2, which is non-insulin dependent diabetes, but does not appear to exacerbate diabetic retinopathy, nephropathy, or neuropathy. Gestational diabetes occurs in approximately 4% of pregnancies, but the rate is above average in people with certain ethnicities like non-Hispanic, Asian or Asian, Pacific Islanders, and Hispanic Latino. Women with gestational diabetes are at increased risk of type 2 diabetes in the future. So gestational diabetes development in a pregnancy is may be a risk for later on type 2 diabetes mellitus. So our lecture today is depending on the guidelines from the NICE guidelines, which is the National Institute for Health and Care Excellence. At the start, we should know the pathophysiology of diabetes or gestational diabetes and the pathophysiological consequences of gestational diabetes. As you know, the placenta secrete many hormones like human placental lactogen, progesterone, and estrogen. All of these hormones may lead to increased insulin resistance in the mother. Also, in the mother, due to increase of the hormone estrogen, there will be an increase in cortisol, which also may lead to insulin resistance. Insulin resistant per se in the pregnant mother may lead to increased maternal blood glucose level and increased fat metabolism. Maternal blood glucose levels which increase also the fetal blood glucose due to the transplacental free movement of glucose across the placenta. Also from the fetal point of view, increased blood glucose will lead to increased fetal insulin, which may lead to the mentioned consequences here. As we know, insulin is an anabolic hormone, so there will be an increase in anabolism in the fetus, increase glycogen synthesis, increase lipogenesis. All of these, which are anabolic effects of the hormone insulin, all of these will lead to fetal macrosomia. So, what are the risks of diabetes during pregnancy? As we know, diabetes during pregnancy increases fetal and maternal morbidity and mortality. Broadly speaking, neonates are at increased risk of respiratory distress, hypoglycemia, hypocalcemia, hyperbilirubinemia, polycythemia, and viscosity. So why these complications occur in a neonate of a diabetic mother? Respiratory distress risk increase in the neonates of diabetic mothers due to the lung immaturity, prematurity, and also due to fetal hyperinsulinemia, because fetal hyperinsulinemia interfere with the synthesis of surfactant. Why hypoglycemia occurs in neonates? Due to the free transplacental movement of glucose in the intrauterine life, there will be a fetal hyperglycemia and increased synthesis of or secretion of insulin. So there will be a neonatal hyperinsulinemia predisposing the fetus, especially in the early days of fetal life, into hypoglycemia. Hypocalcemia, why it occurs in infants of diabetic mothers? Because of the increased maternal urinary excretions of magnesium, so there will be fetal and maternal hypomagnesemia, and as we know, hypomagnesemia create a state of functional hypoparathyroidism. Hyperbilirubinemia, why it occurs? Hyperbilirubinemia also occurs due to, in the neonates, I say, due to the liver enzymes immaturity. Also, it occurs due to increased RBC lifespan, so it will predispose to hyperbilirubinemia. Polycythemia and hyperviscosity, why they occur? During intrauterine life, there will be decreased transplacental transport of oxygen to the fetus, and also fetal hyperinsulinemia leads to increased fetal oxygen requirement, so it will predispose the fetus to polycythemia and hyperviscosity. So we can divide the complication or risk of diabetes during pregnancy into early and late. Early complications, which occurs due to poor control of pre-existing or pre-gestational diabetes or gestational diabetes due to during the period of organogenesis, which is about 8 to 10 weeks gestation, increase risk of the following: major congenital malformations and spontaneous abortion. Later on, poor control of diabetes later in pregnancy increase risk of the following: fetal macrosomia, preeclampsia, shoulder dystocia, cesarean delivery, stillbirth. However, gestational diabetes can result in fetal macrosomia even if the blood glucose is kept nearly normal. So this is the risk of diabetes. Even controlled diabetes during pregnancy may predispose into fetal macrosomia. So why fetal macrosomia occur? Fetal macrosomia occur due to increased transplacental release of the glucose into the fetus, which will be stored as fat. Also, fetal hyper, يعني in the neonatal period, increase in the neonatal insulin level. Also, as we know, it is an anabolic hormone, so there will be a state of lipogenesis. So there will be a risk of fetal macrosomia. Let's start to talk about gestational diabetes. It is the second most common medical disorder complicating pregnancy after hypertension, usually affecting around 4% of all pregnancies. So what are the risk factors of gestational diabetes? According to the NICE guidelines, as I said, body mass index of more than 30 kilogram per meter square, previous macrosomic baby weighing 4.5 kg or above, previous gestational diabetes, first degree relative with diabetes, family origin with high prevalence of diabetes like South Asian, Black Caribbeans, and Middle Eastern. Screening for gestational diabetes. Who are the women who should be screened for diabetes during pregnancy? Those with a previous history of gestational diabetes, women with, as we said, there are risk factors for gestational diabetes. The first important factor it is the previous history of gestational diabetes. So NICE guidelines said that women who have previously had gestational diabetes should be screened as soon as possible with oral glucose tolerance test in the first booking visit, and at 24 to 28 weeks if the first test was normal. NICE also recommend that early self-monitoring of blood glucose is an alternative to the oral glucose tolerance test. Second, women with any of the other risk factors other than a previous history of gestational diabetes should be screened at the 24 to 28 weeks of gestation with the oral glucose tolerance test. So what are the diagnostic thresholds for gestational diabetes? After we have learned the risk factors for gestational diabetes, the risk potential of diabetes upon the mother and the fetus, we should know the diagnostic threshold. How can we diagnose a pregnant female with gestational diabetes? Firstly, there are two criteria. Fasting blood glucose is more than or equal to 5.6 millimole per liter, which is equal to 100 milligram per deciliter. Second, 2-hour blood glucose level in the standard oral glucose tolerance test is more than or equal to 7.8 millimole per liter, which is equal to 140 milligram per deciliter. So these are the diagnostic threshold for gestational diabetes. How do we treat diabetes mellitus in pregnancy? Broadly speaking, close monitoring is very important, tight control of the blood sugar, and management of complication. It is very important to do preconception counseling and optimal control of diabetes before, during, and after pregnancy to minimize the maternal and fetal risk mentioned before, including congenital malformations. Because malformations may develop before pregnancy is diagnosed, the need for constant strict control of blood glucose is stressed to women who have diabetes and who are considering pregnancy or who are not using contraception. So, to minimize the risks, clinicians should do all of the following. First, should involve diabetes team, including physicians, nurses, nutritionists, social workers, and a pediatrician. Second, promptly diagnose and treat complications of pregnancy, no matter how trivial, plan for delivery, and have an experienced pediatrician present. Third, we should ensure that neonatal intensive care unit is available after delivery. Management of gestational diabetes. NICE guidelines has released these points regarding the management and treatment of gestational diabetes. First, newly diagnosed women should be seen in a joint diabetes and antenatal clinic within a week after diagnosing a pregnancy. Women should be taught about self-monitoring of blood glucose, which is very important. Advice about diet, including eating foods with a low glycemic index like brown rice and brown bread, and exercise should be given. If the fasting blood glucose is less than 7 millimole, which is less than 126 milligram per deciliter, a trial of diet and exercise should be offered. So, if the fasting is less than 7 millimole or less than 126 milligram per deciliter, a trial of diet and exercise should be offered for 1 to 2 weeks. Failure of this lifestyle modification after 1 to 2 weeks should the patient should be managed here with metformin, should be started. Still, if the glucose targets are not met after diet and exercise and after metformin, and still the fasting blood glucose is less than the target not met, so the patient should be treated now with insulin beside diet, exercise, and metformin. We should know and emphasize this important point. Gestational diabetes is treated with short-acting, not long-acting insulin. Why? To avoid the risk of hypoglycemia associated with longer-acting insulin. If at time of the diagnosis, the fasting glucose level is more than or equal to 7 millimole, insulin should be started here. So, metformin, diet, and exercise should be started if the fasting is less than 7 millimole. If it is more than or equal to 7 millimole, insulin should be started from the start. If the fasting plasma glucose level is between 7 to 6.9 millimole per liter, which is equal to 110 to 125 milligram per deciliter, and there is evidence of complications like macrosomia or polyhydramnios, insulin should be offered. This is very important point to know about the oral hypoglycemic agent. Usually they are not useful and contraindicated during pregnancy. The only acceptable one, it is as Nice said, it is glibenclamide, Daonil. But there are conditions for its use. These conditions, which are offered by NICE, only to women who cannot tolerate metformin, or those who fail to meet the glucose targets with metformin but decline insulin treatment. Those women are offered glibenclamide. So how can we manage pre-existing diabetes? Weight loss for women with BMI of more than 27 kilogram per meter square. We should stop all oral hypoglycemic agents apart from metformin, and we should commence insulin. So metformin can be used, but insulin is the best in pre-existing diabetes. Due to the higher risk of congenital malformations in patients with pre-existing diabetes who become pregnant, folic acid should be given in a dose of 5 mg per day from preconception to 12-week gestation. That's to say the period of organogenesis to avoid congenital malformations. Detailed and normal scan at 20 weeks, including 4-chamber view of the heart and outflow tracts, should be instituted for pregnant women with pre-existing diabetes to look for congenital malformations, including CNS and cardiovascular malformations. Tight glycemic control reduces complication rate. We should treat retinopathy as it can worsen during pregnancy. So what are the targets for self-monitoring of pregnant women? After we taught the women about the self-monitoring of their blood glucose at home, we should learn the patient and teach the patient about the targets. Fasting should be less than or equal to 95 milligram per deciliter. 1 hour blood glucose after meals should be less than 140 milligram per deciliter, and 2 hours blood glucose after meals should be less than 115 milligram per deciliter. So these are the targets, glucose targets, which are acceptable for diabetic mothers. Insulin, as we know, is the traditional treatment of choice. Why? Because it cannot cross the placenta and it provides more predictable blood glucose control more than the oral hypoglycemic agents. So it is used for type 1 and type 2 diabetes and for some women with gestational diabetes, as we said before. Of course, human insulin is preferable if possible because it minimizes antibody formation. Because insulin antibodies, if they develop, if we use animal source, can cross the placenta, but their effect on the fetus is unknown. In some women with long-standing type 1 diabetes, they may have hypoglycemic unawareness, so they cannot predict their hypoglycemic attacks. Why? Because of the poor control before pregnancy. So there will the normal release of counter-regulatory hormones like catecholamines, glucagon, cortisol, and growth hormone is decreased. Thus, too much insulin can trigger hypoglycemic coma without premonitory symptoms. So we should be careful for women with type 1 diabetes mellitus who may have hypoglycemic unawareness. All pregnant women with type 1 should have glucagon kits and be instructed, as should family members also be instructed about the use. And we should teach them to use glucagon if severe hypoglycemia indicated by unconsciousness, confusion, or measurable level of blood glucose which is less than 40 milligram per deciliter. Regarding the oral hypoglycemic drugs in diabetic mothers, metformin being increasingly used to manage diabetes in pregnant women because of the ease of administration, low cost, and single daily dosing. Several studies have shown that metformin is safe during pregnancy and that it provides control equivalent to that of insulin for women with gestational diabetes. For women with type 2 diabetes before pregnancy, uh, data from use for use of oral drugs during pregnancy are scant, so insulin is most often preferred. Oral hypoglycemics taken during pregnancy may be continued postpartum during breastfeeding, but the infant should be closely monitored for the signs of hypoglycemia. Regarding the management of complications, although diabetic retinopathy, nephropathy, and mild neuropathy are not contraindications to pregnancy, they require preconception counseling and close management before and during pregnancy. Retinopathy requires that the ophthalmologic examination should be done every trimester. If they develop a proliferative retinopathy at the first prenatal visit, photocoagulation should be used as soon as possible. Regarding nephropathy, particularly in women with renal transplants, predisposes to gestational hypertension, so the risk of preterm delivery is higher if the maternal renal function is impaired or if transplantation was recent. So the prognosis is best if delivery occurs more than or equal to 2 years after transplantation. Congenital malformations, which occur due to diabetes in pregnancy, is estimated or predicted by the hemoglobin A1C levels at conception and during the first 8 weeks of pregnancy, which is the period of the most important organogenesis. So if the level was more than or equal to 8.5% during the first trimester, the risk of congenital malformation is significantly increased and targeted ultrasonography, and we should also do fetal echocardiography. It should be done during the second trimester to check for malformations. If women with type 2 diabetes take oral hypoglycemic drugs during the first trimester, fetal risk of congenital malformations is unknown. How do we deliver the fetus of diabetic mothers? So the labor and delivery in gestational diabetes or pre-existing diabetes is similar. Timing of delivery depends on the fetal well-being. We should teach the mother to do the fetal kick count, which means the fetal movement during a 60-minute period daily. And we teach the patient to start this count from the 32 weeks gestation onward. If there is any decrease in the fetal kick counts, so we should if there is any decrease in the fetal kick count, we should give an idea to the obstetrician, especially if the woman have hypertension or have renal disorders or fetal growth restriction is suspected. We may do the fetal kick count earlier than that. When we shall do amniocentesis to assess fetal lung maturity, it may be necessary in the following situations: obstetric complications in the past pregnancies, inadequate prenatal care, uncertain delivery date, poor glucose control, or poor adherence to therapy. What is the type of delivery in diabetic mothers? Type of delivery, usually it is normal, spontaneous vaginal delivery at term, but we should also know that the risk of stillbirth and shoulder dystocia increase near term. Thus, if labor does not begin spontaneously by 39 weeks of gestation, induction should be ensured. Dysfunctional labor, feto-pelvic disproportion, or risk of shoulder dystocia may make cesarean delivery unnecessary. What shall we do in the postpartum period after we manage the diabetic mothers during the maternal life? What shall we do postpartum? We also know that after the delivery, there will be loss of the placental hormones, which are synthesized by the placenta, which antagonize the insulin throughout pregnancy and decrease. So these after delivery decrease, the level of these hormones will be decreased, and the insulin requirements will be decreased immediately after delivery. Thus, women with gestational diabetes and many of those with type 2 diabetes require no insulin postpartum. But for women with type 1 diabetes, insulin requirement decrease dramatically, but then gradually increase after about 3 days. During the first 6 weeks postpartum, the goal is tight glycemic control. So the glucose levels are checked before meals and at bedtime. We should know that breastfeeding is not contraindicated, but may result in neonatal hypoglycemia if the women or the mother use the oral hypoglycemic agent. So women who have gestational diabetes should have a 2-hour oral glucose tolerance test, which is the standard 75 gram of glucose at 6 weeks and 12 weeks postpartum to determine whether diabetes has resolved or not. Key point from our lecture: diabetes in pregnancy increase risk of fetal macrosomia, shoulder dystocia, preeclampsia, cesarean delivery, stillbirth, and if pre-existing or gestational diabetes is poorly controlled during the period of organogenesis, major congenital malformations, and spontaneous abortion. We should screen all pregnant women for gestational diabetes using the oral glucose tolerance test. We should involve the diabetes team if available and aim to keep fasting glucose less than 95 milligram per deciliter and 2-hour postprandial levels at less than 120. We should begin antenatal testing at 32 weeks and delivery should be started by 39 weeks. We should adjust insulin dose immediately after delivery of the placenta. Thank you very much.